All right, first we're going to take a question from the audience. Does anyone have a question they'd like to ask? We'll go right in front. They're going to bring you a microphone, so just hold on one second.
Thank you, everyone. Can you hear me? I just wanted to ask, this is a question maybe for Dr. Greenberg about the Q-cell research that you're doing. For some of my friends who are, have NMO and MOG who are completely blind, is that something that maybe a direction where that research would be helpful or where that could go in the future? I know you were just talking about it for spinal cord repair.
Mm-hmm. Yeah, great question. So for anybody with neurologic deficits from a central nervous system injury, optic nerve, brain, spinal cord, ultimately these cells could be useful if there are intact axons left that are lacking myelin. And so there are some people in the world who've had optic neuritis who lose their vision, whether it's from neuromyelitis optica or MS or any of these conditions, where they've lost vision, but there are axons there. The wires are still there. They just need new myelin. We would expect this cell to help. If somebody's deficit is because the axons have been cut, then regrowing the myelin won't bring back the function. So a lot of the work we're doing and listening to the imaging talks was important for all of us in the field because we're trying to figure out who's who. Can I reliably pick who has a wire that's intact but lacks myelin? And we're working on that part.
We had a question right over there.
Again, for Dr. Greenberg. The injection that you were talking about for the Q cell,
Yeah.
is that going to be specifically in one spot, or is it going to be random in the spine?
So we are targeting, so it's a surgery, you're taken to the operating room, back is opened up, the spine is opened up, and then there's a series of injections directly into the spinal cord where the damage has been done. And for the phase 1 trial, we're approved to do up to 10 injections of a certain amount of cells. And so we're going to go from the top of a lesion down to the bottom of the lesion, spacing out the injections. What happens in animal models is when you inject these cells, they migrate a certain distance. But if I inject the middle of the cord, they're not going to go over the entire cord. They'll inject maybe a centimeter in each direction. And so if we have multiple centimeters we have to cover, it's more than one injection.
Okay, we have a question back there.
I want to thank you so much. I think it's been very exciting to see kind of what the future is in terms of both the diagnosis and treatments in myelitis. My question is, it's actually twofold. One is, and it has to do with reimbursement. So how are we kind of educating the payers in terms of, you know, ongoing treatment options and paying for those treatments currently? And then how are we educating them for the future in terms of what could come out of these research trials? And then the Tesla 7, absolutely amazing. You know, will there be a difference in they'll pay for the 3 strength and they won't pay for the 7 strength, which gives us a better idea of diagnosis and treatment. So it's really around payers and treatment.
Janet, well, we were talking about this morning somewhat in terms of the payers and kind of the issues we face. I don't know if you want to.
We're more on the rehabilitation side, and you know, ongoing rehab is always a. Are you thinking more of like ongoing rehab?
I mean, for rehab, 30 days, that's all, and see you next year. You know?
Yeah.
I think that's just like very ignorant in terms of realities. It's only 365.
Right.
You know. So we can start there.
Yeah. So pretty much what we do is try and figure out how to maximize those 30 days, and there are some policies where you can ask for more if there's medical necessity, and we would have varying success with obtaining that. But I can let Dennis speak to the kind of things that we do to sort of do home programming and various other things to try and maximize that.
Yeah, well, so I can't speak much for the billing, but one of the big components. So I'm Dennis. I'm a PT at Kennedy Krieger, and one of the big things we do is we create like a pretty extensive home program for patients to do once they're done seeing us. because it's really important to really kind of make the exercise and rehabilitation a lifestyle, kind of like you were talking about during your presentation. And really, I mean, kind of like with any sort of physical activity, you can't really expect to do 30 days of exercises per year and then stop completely and expect to make gains or maintain what you've gained. So it's really going forward with these sort of, all these different neurological disorders, just maintaining that active and healthy lifestyle and trying a lot of the other supplemental types of therapies, whether it's like personal training, horseback riding, et cetera.
I'm thinking that more, if you look at the medical directors within the payers, I think maybe we could do a better job in terms of looking at the medical infrastructure of the insurers and try to bridge that gap a little bit more, so that I think more emphasis can be put on within these disease processes and opening up of better reimbursement.
I actually have some thoughts on this too. So my PhD was in public health and epidemiology, and I think you're making a really strong argument for better data on the economics. And so sometimes spending more is cost effective. So if you look at the burden, the financial and the personal and the social burden for people who have these conditions of a variety of different sorts, you can make a strong argument with data that you are actually saving society money by spending more money early on in treatment and rehabilitation. But if you don't have those data and that registry and someone analyzing the data to make that argument, it's really hard to convince policymakers. So actually putting some force behind the economics research is really important for patients too.
Thank you.
I think it's a really important question. It takes on so many different forms, whether it's for rehab or for coverage of IVIG. We spend an inordinate amount of time with prior authorizations, appeals, peer-to-peer phone calls. I'm going to sound somewhat skeptical, but I actually don't think that the medical directors of the insurance companies are interested. And I would suggest, and probably we could do it as a field, do a better job as well, but to put pressure on, whether it's through patient advocacy groups, but also through the government and elected officials in the state of Massachusetts. And in one particularly egregious situation, this came in handy, which was the Office of Patient Protection in Massachusetts, and it had to go to that level to get approval for a necessary therapy. So I've become more jaded, unfortunately, over time. So I would just say, speak up, talk to your elected officials, and try to, put pressure on the insurers.
Thank you.
We have a question down here in front.
Dr. Greenberg, if you participate in the stem cell trial when the FDA does approve it, will you be disqualified to have the injection once the FDA, because the first trial is only going to be one series of injections, and they might need more than one series of injections, correct?
Yeah, so once the FDA approves it, so the question for those in the back were, if you take part in the trial and the FDA approves it, would you be able to go on and get more injections? And the answer is yes. When the FDA approves a therapy, it's then up to clinicians and, to the question in the back, third-party payers to decide about using it, but being in the trial wouldn't disqualify you. Being in the trial may disqualify you from being in other trials, but once approved, you would have equal access.
Any more questions in the audience?
A few years ago, I saw this picture of a mouse, and he had a human ear on his side. They had grown there. You think that was a fake story?
That's definitely Mike. I think that it was his lab.
Oh, no. Well, what that... No, that wasn't mine.
Did you ever hear of that?
It's not a fake story. What it is it's a demonstration that you can grow human tissue in a mouse from stem cells, and it just depends on where those stem cells come from and the environment in which they're grown. And so those tissue cells are not complicated cells. They're cartilage and skin. So regrowing a nervous system would be much more difficult, but it is a nice demonstration of the power of a stem cell.
It can be different species. A human being is different than a mouse, you know?
Only slightly.
Remember Christopher Reed? and you know who he was?
Superman?
Yeah. And when he was alive, he would stress stem cell research all the time. Was it because the government wouldn't allow it then? Never got to see that.
No.
No, so the issues around stem cell research obviously have been controversial for a long period of time, and obviously it has to do with the source of the cells that leads to a lot of conversations. A lot of the time in the United States has been spent, and worldwide, trying to sort out how to control the cells. It's getting back to put a stem cell in unrestricted has a lot of risk to it. So there's probably a solid 20 years worth of research that was done to figure out, when we inject the cell, can we predict that it's going to do what we want it to do? There were laws passed that changed the ability for the NIH to fund research with embryonic stem cells outside of very specific lines, and that definitely led to some labs not being able to pursue some work that they may have wanted to. We got into a similar situation in the great state of Texas. Just a year ago, our legislature passed a law outlawing state institutions, and I am a state employee, from doing stem cell work with embryonic-derived stem cells. And the way the law was written, it was actually going to prohibit our clinical trial. And through a lot of advocacy and discussion, there was an amendment put in that said if the cells existed prior to a certain date, that you could go ahead, and the date was picked to make sure that the cell line we're using was already in existence. So there's a controversial area, and I understand the controversy and the sentiments around it. But it wasn't just the politics. There's a lot of research that had to happen as well simultaneously to be able to move forward.
I always thought stem cells came from embryos. I didn't think it came from other parts of the body.
Yep, there are different places you can go.
We have a question right here. Hold on one second. They're coming with the microphone. Just raise your hand high. Oh, you got one? Okay.
I just wanted to know, did you say earlier that like a traumatic injury, like a brain injury, or could cause transverse myelitis or myelitis? Or if someone had myelitis already and then received a traumatic injury, like a brain injury or a head injury or another injury, would that then cause them to have another attack?
Are you referring to my talk?
I don't remember
Maybe.
who said it, but I remember it was the idea that some of it can be caused by brain injury or traumatic injury.
Not brain injury. So when they looked back in that certain study at events that had happened before the onset of the myelitis, there were some patients who had minor trauma. It didn't really specify which part of the body had had trauma, and certainly I don't associate brain trauma with myelitis, although we have seen, neck or back injuries at times suspected to be associated with some cases of myelitis. Does that clarify?
Well, then if someone had myelitis and then got a traumatic injury, could that then make them have another attack?
I generally don't worry about that. I haven't seen that. Others can disagree with me, but
I keep hitting my patients over the head and they seem fine. but that's just their bill, so different trauma.
We'll do the question in the back, and then we'll come to you. So right back there in the purple.
Okay, this is for Dr. Levy, and I know nothing. You can see I know nothing about science with this question, but you were talking about West Nile and gene mutation, and I thought that West Nile was caused by mosquito bites. How does that relate to gene mutation?
I didn't mention West Nile. I'm trying to think what I said that.
It was on the slide.
It was on the slide?
It was on your
What
slide.
did I say?
It was
I'm
on your
honestly
slide.
lost.
It said
my
West
finger.
Nile.
I think it's similar to like the HSV TLR, that there are certain
Okay, I know what it is.
neuroinvasive disease.
Right, so there are predispositions. So there are, you can have certain genetic mutations that predispose you to an autoimmune reaction or an infection even. So people who have infections with the herpes virus or West Nile virus, they'll often test that involve the nervous system. they'll often test positive for a certain genetic configuration that makes them more susceptible.
Yep, so just to be clear, the genetic mutation makes them more susceptible to a neurologic complication. So there'll be thousands of people infected with the West Nile virus, but only one gets encephalitis. Why did that one get encephalitis when so many people were infected? And there's data to say that certain hosts with certain genes handle the virus differently and are prone to the complication.
In fact, there's a study at Johns Hopkins looking at genetics of acute flaccid myelitis and trying to see if there's any genetic signals there, which is exciting.
Okay, we're going to go right over here.
Have any of you guys seen or discussed any connection between pregnancy and transverse myelitis, or is it just women are more susceptible to getting sick because their immune systems are suppressed? Or have you seen a lot of pregnant women with TM?
The pediatricians want to answer it? No. I don't think, I'm trying to make sure there's a fact-based statement. If I have, it's only been one. I don't think I've had any cases of transverse myelitis during pregnancy. Have you had any?
No. Is that
No?
what you're asking?
Yeah, my sister was diagnosed while pregnant
Yeah.
several months ago, and I was just wondering, are there?
Do you know what the final diagnosis is? The cause of the transverse myelitis?
I was talking to Dr. Greenberg about this. The Hopkins doctors and the Columbia doctors differ, but they think it's a post-viral infection that, I don't know if that's the right.
So the reason I'm reading Mike's mind right now, the reason is there are certain systemic conditions that can cause transverse myelitis that sometimes in certain phases of pregnancy we may see relapses or immediately postpartum. And so there was some data on NMO that was presented. I have not seen MOG data presented. And so I don't know of an association between pregnancy and transverse myelitis, but whenever somebody has one of the events, no matter what, they should have a full workup for some of those secondary causes. And if they were seen at Hopkins, I guarantee they did it because, you know, it's Hopkins.
They're the best.
Yeah.
Do we have any other questions in the audience? Yes, they're coming with the microphone, so hold on one second.
With that secondary cause workup you were just mentioning, now I live in New Hampshire, and I got Dartmouth, and they're good, but I don't think anyone really took it farther than like my initial diagnosis. You know, they didn't see it in imaging. They treated the symptoms immediately. I had a pretty good turnaround. I walk, you know, I had to learn all over again, but I walk, I work, I do all these things, but I don't think anyone ever really took that next step. Is that something I should pursue? This stage in the game?
Yeah, I think in general, our recommendation is everybody who has had inflammation within the central nervous system should have an evaluation for whether or not they're at risk for inflammation coming back in the future. There's a good literature on the transverse myelitis website in terms of what that workup entails. I will mention that a lot of times clinicians will do blood testing or other tests on patients, and if the test is normal or negative, they won't tell you about it. So sometimes I'll have people come to me in clinic and say, I was never tested, and I have the result that they were just never communicated with what testing happened. And so it's worth having always conversation with your clinician to make sure that a workup's been done.
Thank you.
They're coming with the microphone. Hold on, just keep your hand up high.
I just had a question about the acute flaccid myelitis, and if you had a diagnosis done prior to the definition of that. Our son was diagnosed before AFM was broken apart from TM, and I was curious if it's possible to have flaccidity, I guess, at onset, but then develop spasticity much later, and whether that indicates gray matter involvement.
I don't think that flaccidity, I think it's an individual experience. I've seen patients with AFM who do have some spasticity, and I've certainly seen patients who didn't have AFM and had more of an idiopathic TM who are still flaccid. So they don't perfectly differentiate each other. It's more of the whole clinical picture when the spasticity and the flaccidity evolve, the reflexes, and the pattern on the MRI often is very helpful.
Is it important to find that, or to, I guess, reopen that and look and determine whether or not that diagnosis needed to be changed, or is it pretty much null and void at that after years?
I think after years, if you sort of hit a plateau and are doing well, I don't know if there's a big difference in rehashing, as long as we've ruled out those MUG and NMO and MS things that may come back and cause additional problems.
Thank you.
Can we just get a microphone down in front? Just raise your hand up high.
This was a question on my card, so I don't know if you're going to get to them, but it's there's a study on CLP 209 that Dr. Benson, something about paralyzed mice regained movement in their legs with some protein in the spine. That was
now I know what you're talking about. It's not something that I'm directly involved in. I don't think either of us are, but I've seen it kind of come across the media through children's. I think it's in very early stages in kind of PhD labs under investigation.
Are they looking at it for in a demyelination case, or like a sever? I don't know if I'm using the right term.
I don't remember the details. I'd have to read again and chat.
Okay. It'll be on my list in February.
Send it to me in advance, please.
Can I just add one quick thing to that? I get calls from pharmaceutical companies a lot because they're going back to their medicine cabinets of drugs that were approved or were developed in the past, and they're trying it in different model systems just to see, for example, if they stimulate myelin growth. And then if they do, then they've called me and they said, hey, can you throw this in your mice and see if it helps in a clinical situation? So I think there are a lot of companies who've looked at these Biogen trials that Dr. Greenberg talked about and the other trials, and who said, you know what, we should go back and look at all of our drugs and see if they do anything helpful for myelin repair. So, no, not that specific one, but it sounds like things that I evaluate all the time from these companies who are just interested to know if their drug helps. Most of the time it doesn't, but a couple of times it does.
I'm going to go for a question that was asked. Is it better to rest on days that symptoms, pain, are extreme, or just to exercise and work through it?
Janet?
I think the most important thing is to listen to your body. You're going to want to make sure that you do give yourself that rest. And I think it's going to be important to get on a pain management regimen and trying to get that under control as best as you can. But if it's from overuse, like if you were working hard in PT the day before and you're in pain the next day, it is important to get some rest or do something that's less impactful, like swimming in the pool, for example, can still work your body but not kind of give you that. The pool can actually help with the pain a little bit as well. So I don't know if you have anything to add, but.
I mean, so a lot of people respond like with pain, mobility, and exercise can actually help with that. So if you're having severe pain and you try some exercises and you're feeling better, I would say continue exercising then. If the pain is getting worse with all that movement, then I'd say probably back off and rest and then do more either relaxation things, stretching, aquatic therapy, stuff like that.
Okay, we have a question over there, so hold on.
Hi, sorry. So I just had a question about the concept of monitoring for MS when you're diagnosed with idiopathic TM. My neurologist, Dr. Becker, he runs all the tests and stuff, everything. And he said for the first 10 years to get an MRI every year. I just didn't know what everybody's thoughts were in that, and making sure I'm not being like, I don't know.
I heard he owns the MRI machine, so I don't know if that, anyone, no. So anybody who's had inflammation within the nervous system, one of the things on the differential is multiple sclerosis. And if we can't make the diagnosis at first, if you don't fit the criteria for MS, you fall into two categories, either a high risk, where we have a high suspicion of MS, or a very low risk. And there are things we can do with testing to put you into one of those two categories. It is not unusual in either category to look back with an MRI, but especially in the high-risk group, more frequently. Some folks, if you're in a low-risk group, will do an MRI at some point or a few points over time. Most of the data for MS that I've read suggests, in the adult side, a little different in kids, but most of the data suggests that if you're going to declare yourself that it's MS, the majority of people do it within the first 5 years. And so it's not unusual for us to take a look somewhere in that range, but it depends on your individual characteristics, how far we keep going.
Just to add to that, there's no consensus on this, so there's not one right way to proceed. And I agree, there's certain potentially prognostic factors about each individual that may guide, but they're not clear. So you can still, even having all the information at the beginning, you can still be wrong. So some people are more vigilant than others. What I do is usually kind of graduate people off of imaging over time. So if you look like in the first few years you haven't had any changes, I may wait even like 18 months or 24 months. The inter-attack interval, so the time that most people are going to relapse if they have MS, is about 2.5 years, 2 to 2.5 years. So that's the most people, if they're going to have a second event, it's by then. But it's not off the charts that you could still always have an attack later if you're at risk for MS. So it's not wrong to be careful.
Okay, well, I have a question as a parent. For those who haven't heard of this, my son has AFM, and can you explain what recrudescence is?
So recrudescence is the obscure word that we use to basically refer to the situation where there is not a new acute inflammatory relapse, but that old symptoms can reoccur in the setting of a systemic stress. So the classic would be that a patient who's had, let's say, myelitis and has weakness, but recovers strength, and then gets an infection with a fever, and their weakness recurs. But once the infection and the fever goes away, then their strength returns. And it's not that they have a new injury to the spinal cord. It's that the injured area functions differently in the setting of infection and fever versus the baseline.
Thank you.
So it returns on its own. The key things would be, assess like for example, what's the trigger for the recrudescence, and to address the trigger. So if it's a bacterial infection, then you treat the infection. If there's fever, control the fever. Sometimes it happens in the setting of heat. Sometimes it can happen in the setting of psychological stress. So it's about addressing the trigger. You don't need to use anti-inflammatory treatments. But it is important. It's not always totally clear, and so a lot of times it's frequent visits, checking in frequently, making sure that the patient is going back to baseline, and typically relatively quickly. And it's well described in MS. That's probably the most literature that we have, and I think in AFM we're learning. If there was any doubt about whether it was recrudescence versus a truly new attack, then yes, I would get objective data, which might be an MRI, might even be other tests as well.
And is there like a difference if you're having weakness in the areas that you already have weakness versus new areas?
Yeah, it should for recrudescence it should only be areas that were previously affected, not new areas or new symptoms.
Thank you. We have a question right over here.
So I'm going to come off of your question. Does that go for TM as well? Because I totally, I'm like, oh my God, if I have a virus, I feel like I flare up, and sometimes I'm like, is that normal? Or, so is it the same sort of thing we're talking about?
Completely.
Okay.
So there was a syndrome described over 100 years ago called Uthoff's phenomenon. So a German physician described this long before MRIs. that if you have a damaged part of the nervous system, the optic nerve, spinal cord, and you recover function two ways: repair and compensation for the damage. When your body gets systemically stressed, infection, heat, stress, lack of sleep, lack of hydration, kids are annoying you, whatever the case may be, when that physiologic stress occurs, your body's ability to compensate for the scar goes down, so the old symptoms come back, which is different than a new attack. So I have one patient where every time she and her husband fight, her symptoms come back. So my prescription was stop fighting. For other people, it's heat. For some people, it's urinary tract infections. It can be different triggers for each person, but it's very normal to have the recrudescence of old symptoms after any of these injuries.
Okay, thank you.
We have a question in the back.
Will there be any pediatric patients included in the first clinical trials?
For the stem cell?
Yes.
No, the first trial, the IND that the FDA granted, it's restricted to 18 and older in the first trial. So the first 9 patients will all be adult.
And then how many trials do you think it'll be before you would be trying pediatric patients?
Once we see the safety data from this phase 1, there's going to be a sit down with a lot of folks to decide where to go from there, depending on the safety. And the decisions that are going to be made include inclusion criteria based on age, inclusion criteria based on how far from the injury does somebody need to be. There are a lot of variables that could change. But we have no objections to moving into the pediatric world if we get enough safety data and it looks good in the first trial.
I'd just like to thank all of you so much for being here today.
We have a question over here.
Just wondered what your opinion was in terms of kind of going off of your questions about flare-ups. Our son has started school and he will soon be pressured to get the next immunization required for school. And I know that some parents I've spoken to have decided to do a graduated immunization because the next immunization is one needle with about 4 different things in it. But I'm a bit concerned that maybe one of those 4 different things is going to cause flare-ups of issues that he's experienced in the past that we've made gains and we don't want to go backwards. So what's your opinion on that?
Mark, you want to go first?
So the thing we get a lot of questions about vaccines, and the data that we look at to try to make an individualized recommendation are, number one, what's the underlying condition? And that influences a lot. Is it the type of condition that we expect to be a one-time event, or does it have the potential to be chronic and recurrent? The second then is, was there any timing association with the vaccine for the first event? Then we also look at kind of risk-benefit analysis of the particular vaccines, because there's definitely some vaccine-preventable diseases that you would not want to get. I would say after doing those equations, I would say by and large, most of the time we are recommending full vaccination schedules, but it's individualized to the specific patient.
So would you say that our complex care pediatrician would be the person to ask specifically about that, or say the neurologist that's following us?
I think it would be a joint discussion would be the ideal. Yep.
Okay, thank you.
I think it's worth mentioning one thing. To my knowledge, for idiopathic transverse myelitis and for acute flaccid myelitis, I am unaware of a single recurrent event post-vaccination. And so I have not read, heard, or been instant messaged about a single recurrent event. So our sense of safety around this has some evidence behind it for those idiopathic one-time events, as Mark was talking about.
Including flu shot?
Including flu shot.
Yep. Right here.
Okay, hopefully I'm saying this right. Dr. Levy? Mm-hmm. Okay. Have you looking, since you already have the DNA from multiple TM patients, have you looked at seeing if they have mutations or variations in the rest of the what's ESCRT, vesicle recycling, like that whole process to see if maybe there's other mutations?
Yeah, we put in a grant to do that. It costs, so one thing I want to do is thank the TMA. They paid for sequencing for about 50 patients with transverse myelitis and all the FedEx and shipping that cost $25,000. So I just wanted to thank them for doing that, make this possible. To be able to do the rest of the genome would be pretty expensive, so we put in a grant from the government. I think they're interested, but we'll have to see if we can do that.
Oh, we have a question in purple. Keep your hand up high. They're coming with a mic. And then we'll do the question in the back.
Dr. Greenberg mentioned about biotin might be helpful in remyelination. Now, I know you're doing studies on it, but would it be beneficial to someone to maybe take biotin? Because you can just take that over the counter. Would that help? Or also, if it's caused by a virus, one of these myelitis, would an antiviral be helpful to people?
So on the first question about the biotin, the study that's going on right now utilizes a dose that's 300 times greater than what's available over the counter. And so you have to get 30 bottles and take them once a day and stuff like that. You can go through a compounding pharmacy to get high-dose biotin off-label. It's under study from a safety perspective to see if there are any issues with taking that high dose. So it's unclear yet. We don't have data yet to comment conclusively on safety. There is one patient safety issue that's already been identified, and that is there are certain blood tests that are routinely done in healthcare that will be interfered with if you're taking high-dose biotin. So the best example is thyroid function tests. So if you're on high-dose biotin and your internist checks your thyroid, the next day they're going to call you and say, you need thyroid supplementation. Your thyroid's fine, but the high-dose biotin messed up the assay, so they were getting a wrong result. And there's a long list of blood tests that can be interfered with. So one of the patient safety issues isn't about adverse events, it's about could you be given bad advice based on a bad blood test because they don't know they're on the supplement or how it will interact. So there's more work that needs to happen around the high dose. Relative to antivirals, in the acute setting, there have been discussions of would an antiviral help in the setting of acute flaccid myelitis or other conditions that are thought to be virally associated. We don't have an antiviral that's proven against this enterovirus, so there's not one that actually works. There have been suggestions of high doses of Prozac. Turns out it doesn't work for this strain of the virus the way we thought it would. And there are people looking at antivirals, but there's not one available. After the acute setting, I don't know of any data to say being on one of the available antivirals changes recovery or function.
Do we have a question in the back? Yep.
Hello, thank you guys again for all that you guys do. I had a quick question regarding the vaccines with IVIG in particular. When patients are ongoing IVIG treatment, specifically for like MOG, they usually get it every 4 weeks. With that being said, they have the antibodies already in them for vaccination. So if given a vaccination, theoretically, wouldn't the community immunity that they have, wouldn't that already attack the vaccines and not allow their bodies to produce it? What are your ideas on it, and should they be vaccinated, and how?
I can chime in. Everyone should chime in on this one. It's a great question. So there's two parts to the question. One is, if you're on IVIG, do you need the vaccination? And the second is, would the IVIG interfere with mounting a vaccine response? So in general, IVIG will help with preventing infections based on whatever antibodies are there at that time. The antibodies are short-lived, and every batch you get is a little bit different. And what it doesn't create is the other part of the immune system, which are the T cells, which can also be important for fighting certain infections. So when we give a vaccine, you don't just mount an antibody, but you develop anti-infectious T cells. And so by giving IVIG, you'd have the antibodies, but not the T cells. So over time, you may have incomplete protection from infections. And so we would still lean towards vaccinating. There are certain medications, rituximab, mycophenolate mofetil, certain drugs we use in some conditions that we think will definitely reduce the effectiveness of a vaccination. So if you're on one of these drugs and you take your flu shot, you may not mount the same response that you would have off the drug, so it might not be as effective. On IVIG, I don't think that would be the case. You really should be able to mount a response to a vaccine even with the IVIG, but I don't have data to say that. I don't know, Leslie, if you do.
There's guidelines. There's a red book for pediatrics where they talk about the different vaccines and infections, and there are guidelines to suggest delaying vaccination for things like MMR for at least like 8-12 months after you're off of IVIG. So we sometimes consider which vaccine and whether you're better off to wait, because hopefully with MOG, maybe you're not on IVIG for the rest of your life and can kind of reconsider the vaccination status once you're off of it, but we don't know yet, I think.
Elaborate more on the differences between ADAM and A&E, and whether there is genetic markers that can be found in the mom and drug, as you guys found with the animal?
So A&E is acute necrotizing encephalopathy, I think is what you're referring to. And while it can look like an inflammatory disorder, and I think used to be lumped with ADEM, I don't think of it that way anymore. It may respond to some anti-inflammatory treatments, but it's more of a metabolic problem. It's a genetic problem that affects your metabolism and your mitochondrial function. And so I think of that as a very different, distinct disease, not necessarily as a subtype or having a relationship to ADEM or MOG. Whereas MOG and ADEM, we have not yet been able to piece apart fully.
Well, thank you so much to our panelists. We're going to wrap up for our closing remarks, but let's give a round of applause to our panelists.